Hi, Adult Health One. We are doing respiratory today. There's two PowerPoints, 5A and then 5B, okay? Um, Chapter 7 is O2 therapy management. Chapter 23 is respiratory function, and Chapter 4 is infectious respiratory disorders. Chapter 25 and 26, which are on the next PowerPoint, those are upper and lower airway disorders. So there are two. And then we have 2 weeks to cover all that in class, right? Here's our objectives. All right, so, okay. The human body requires oxygen in order to sustain life. The inhaled air consists of 21% oxygen, 78% nitrogen, and 1% miscellaneous gases. Through ventilation, perfusion, and diffusion, oxygen is delivered to the cells and carbon dioxide is removed to maintain proper oxygenation and tissue perfusion. Ventilation is the movement of air in and out of the lungs. Perfusion is the gas exchange of oxygen and CO2 at the alveoli capillary membrane. Diffusion is the movement of solutes from an area of high concentration to an area of low concentration. And you're just going to want to remember the definition of diffusion. Oxygenation is the process of oxygen passively diffusing from the alveoli to the blood, where the oxygen attaches to the hemoglobin or dissolves in the plasma. The process of the transport of oxygen from the inhaled air to the cells and the transport of CO2 in the opposite direction is called respiration. Normal PaO2, or partial pressure of oxygen in arterial blood level, the part this is what we are exerting, right? So oxygen is 80 to 95. And then the normal SaO2, so this is like if you put a pulse ox on somebody, we expect that to be 95 to 99. The PaO2 is related to blood gases, and we are going to talk about that. That's part of Module 6, all right? So don't worry too much about that yet. So when these levels are sustained, the PaO2 is where we like it, SaO2 is where we like it, then there's adequate oxygenation for the body. Disruption in oxygenation can either be in ventilation or perfusion, causing hypoxia, which is, low oxygen related to breathing, or hypoxemia, which is low oxygen in the blood. Hypoxia occurs secondary to insufficient oxygen to meet the metabolic demands of the cells, tissues, and organs. Hypoxemia develops when there are low levels of oxygen in the arterial blood. When there is a disruption in oxygenation, the cells may become hypoxic because of an inadequate amount of oxygen in the system, causing a decrease in tissue oxygenation. So this person, if are people who have low oxygen, we're going to see potentially changes in mental status, anxiety, restlessness, confusion. And this is because the brain actually ends up being deprived of oxygen. Also, their respiratory and heart rates may increase, right? The body is trying to compensate for the fact that there's low oxygen. So we're going to try to get more oxygen in, CO2 out, and then everything's going to go up, trying to utilize the oxygen that we do have, okay? So when this happens, we're going to put people on oxygen. We're going to give them supplemental oxygen. So oxygen therapy is initiated when an oxygenation concentration higher than room air, 21%, is needed to treat or prevent hypoxia. Oxygen is a medication and requires an order from a healthcare provider. So as nurses, that part is important to remember, right? O2 is a med. This is just related to age-related considerations. Like with everything, being older affects how we're able to breathe. So pulmonary function of the older adult undergoes changes, which are not the same in every aging adult and may vary in each individual person. So we lose loss of lung elasticity. Sorry, there was a lot of L's there. There's an enlargement and rigidity of the chest wall. So stuff is supposed to be moving back and forth, and now our chest wall has become rigid. There's a decrease in muscle strength, which doesn't help. You know, we need we need strong core to help breathe, believe it or not. And then there's a decrease in alveolar surface area. So internally also things are shrinking, losing elasticity, they're not able to move air, they don't have the strength, respiratory muscles weaken, all sorts of things. So basically these changes can lead to decreased expansion of the lungs, so less depth with breathing, less effective cough, decrease in gas exchange, and alveolar collapse, all of which affect ventilation and perfusion. So they may just not be able to exchange enough oxygen through the respiration process, right? Due to these, all of these aging things that take place. So they are at greater risk for hypoxia and hypoxemia. Talking about O2 devices, right? Delivery devices, right? Because we have multiple to choose from, and it depends on what's going on with our person as to which one we want to use. As usual with everything, we want to go with the least invasive and the lowest amount possible, okay, to maintain that SaO2, the pulse oximeter, between that, you know, 95 to 99, right? So there's a number of different non-invasive oxygen delivery devices. Some are considered low flow, some are considered high flow, all right? So some of the factors related to how we order which device, how much O2, patient's age, disease process, whether that disease process is acute or chronic, degree of hypoxia, how depleted of O2 are they, and the ability of the patient to tolerate the O2 device that is ordered. You know, some of these devices, nasal cannula, pretty non-intrusive, right? But a mask, and some of the big, we have like a full face mask too, a tent. You know, if our person has, if they don't like feeling closed in and stuff like that, that can be really ineffective for them because it's going to add to anxiety, which is going to contribute to how they feel like they can breathe, right? So let's talk about low flow delivery devices. So this is the nasal cannula, the regular old face mask, partial rebreather, and a non-rebreather. So these low flow delivery systems provide oxygen in concentrations that vary with the patient's respiratory pattern. Supplemental oxygen is mixed with room air, which lowers the oxygen level that is actually delivered to the patient. So like when we say 2 liters of O2, like we set our nasal cannula to 2 liters of O2, the patient isn't necessarily getting that full 2 liters of O2 because it's mixing in with room air, right? So it's kind of, there's a whole, when we talk about vents and whatnot, there's a whole like fractioned air and blah, blah, blah. And that addresses the fact that even though we're set at 2 liters, the person is not getting a true 2 liters, all right? So hopefully that makes sense. It's just mixing with room air. Oh, here it is, the FiO2. So that's the fraction of inspired oxygen. So that is just saying that we cannot totally determine how much oxygen the person is actually getting because it's mixing with that room air. So that's that FiO2, all right? So nasal cannula is used for patients who require low levels of oxygen to maintain adequate oxygenation. And it works well for the patient who has adequate ventilation, but requires a higher O2 concentration than what is available in room air. Oxygen concentrations for nasal cannula is 24 to 44%. Now remember, what's in the air is 21%, right? So for nasal cannula, this is essentially 1 liter to 6 liters per minute is what will run through a nasal cannula. So patients with chronic lung disease or those who require long-term O2 find the nasal cannula easy to use and comfortable to wear. The patient who retains CO2, such as the patient with COPD, will use the lower amount of oxygen, 1 to 2 liters per minute, so that the patient does not lose the hypoxic drive to breathe. And we'll talk about COPD. We always worry that they can end up with oxygen toxicity, because believe it or not, you can flood them with oxygen and it's going to affect the part of the brain that tells them to breathe. So when we are talking COPD, we like a nasal cannula. Just remember, we can run 1 to 6 liters through a nasal cannula, okay? Sometimes we will add humidified air to this. Humidified air just keeps everything from drying up, all the mucous membranes, your nose, inside your nose, even down your throat when you're getting air. That just keeps everything from drying up and causing a cough or more irritation. This is a simple face mask. I'm sure you've all seen this before. This one, we can do flow rates from 5 to 10 liters. All right. So that's delivering oxygen concentration at 40 to 60%, but it's 5 to 10 liters on a normal face mask. This too mixes with room air. We are also going to, you can use oxygenation or humidification with this as well. And the face mask is kind of nice when transporting a patient. It's just easy, pop a face mask on, right? This is a partial rebreather. So partial rebreather is a simple mask. It has a reservoir bag. So you can see that in the picture. There's a reservoir bag. This is figure 7.3. So the patient breathes in the oxygen from the reservoir bag. Then on exhalation, the bag refills with O2, and the exhaled gases exit through small holes on both sides of the mask. So the person's not rebreathing CO2. All right, the CO2 is exiting. We're breathing O2 in from the mask. Oxygen flow must be maintained to keep the reservoir bag 1/3 to 1/2 full on inspiration. So that bag is 1/3 to 1/2 full. Our flow rates are about 8 to 10 liters per minute. And this is good for short-term oxygen therapy, but 8 to 10 liters a minute, all right, on our partial rebreather. This is a non-rebreather. So this is similar to the partial rebreather, except this mask has one-way valves. So there's a one-way valve between the bag and the mask that prevents the exhaled air from entering the bag, thus ensuring a higher, more accurate oxygen concentration in the reservoir. So our problem all along with these O2 devices is that we have room air mixing in, we have exhaled CO2 mixing in, and so our actual O2 that our person is receiving is not as precise as maybe what we would like. So this mask, the low flow O2 non-rebreather, offers a more precise O2 because it keeps that CO2 distinctly separate, and it keeps that room air distinctly separate, all right? So we're just getting a more precise delivery of the O2. So we can minimal flow rate of 10 liters on this guy, and it can actually provide up to 90% oxygen to the patient. So that's a lot. So now we have high flow delivery devices. You may see these on MedSearch possibly. So high flow delivery include Venturi mask, aerosol mask, trach collar, a T-piece adapter, and a face tent. We're going to talk about a trach collar and T-piece adapter when we do our trach care and lab. So these high flow devices deliver set oxygen concentrations regardless of the patient's breathing pattern. So it's not dependent, inhalation of oxygen is not dependent on the person breathing in and breathing out. That oxygen is being delivered, period. This also, we use humidity. Oxygen source is passed through a humidifier that allows the oxygen concentration to be humidified before reaching the patient. Humidifier has a dial that is used to adjust the O2 concentration being delivered to the patient. This provides the patient with concentrations of 24 to 100% O2. Minimal flow rate on these is 10 liters per minute. So the Venturi mask is most commonly used high flow. The device delivers the most accurate oxygen concentration. So that's the Venturi mask, all right? We can deliver 24 to 60% O2. This can range from 2 to 15 liters per minute. Adapter indicates the flow rate of O2 that should be maintained to provide the prescribed percentage of oxygen to the patient. Mask is fitted to the face and an adapter is attached to the bottom of the mask. In this picture here, you can see the little adapters. So each of those has like an O2 flow rate on them. So you pick your adapter. I've also seen it where you can dial the flow rate. The Venturi mask will have just a little dial on the bottom, and you adjust the dial to compensate for that flow rate. This is a high flow aerosol mask. So this is indicated for patients who require high humidity oxygen concentrations. Patients who benefit from aerosol masks who are those who have been extubated. So maybe we've pulled that ET tube. Maybe they're off of their trach, right? Those who have had upper airway surgery or those with thick secretions. This device delivers aerosol therapy that includes humidification and/or medications in order to liquefy secretions for easier removal. I don't know what you guys have seen in the way of secretions, but it is crazy how thick stuff can get. Like think slime, right? So what this does is it goes in, humidifies down all that all that gross secretion, makes it thinner, right? It thins out the secretions so we can more easily suction it out. Maybe more easily the person can cough it out. Because when somebody has thick secretions like that, we always worry about them being able to maintain their airway. I apologize if there's barking in the background in a second here. This is a picture of a trach collar. So trach collar is used for patients with a tracheostomy. This device allows humidified O2 to be delivered to the patient via a tracheostomy collar. You can see it kind of looks like a face mask, but it's a little bit more oblong shaped so that it fits over the tracheostomy. So this allows some O2, humidified O2, to be for the patient to breathe that in through the tracheostomy. Maybe they don't need to be on a vent anymore, but they need some O2 support. So, and we will talk about this one in lab as well. This is a face tent. This is the one I was saying can be kind of cause a little bit of claustrophobia for people. It goes over the mouth and nose. It's giant. We have one in lab that we're going to be able to look at. So this is good for people who have facial trauma, burns, maybe upper airway surgery. The device, it fits under the chin and then extends just above the ears, and this also allows for O2, humidified O2, and it's kind of like a mist just blowing over the nose and the mouth. But notice that it's not really fit to the face, so we're going to have a lot of this O2 that's being delivered is not going to be precise because we're going to have a lot of mixing with room air, right? Because it's very open. This is non-invasive positive pressure ventilation. So this delivers positive pressure to the airway without the use of an artificial airway to keep the alveoli open and decreases the risk of nosocomial infections. Again, in infection control land, we do not use the word nosocomial anymore. They are hospital acquired versus community acquired, right? So anyway, but that's what nosocomial means. It's you acquire it in the hospital, you didn't come in with it, but you don't hear that word anymore. So this is delivering positive pressure, but the person does not have a tracheostomy. So essentially, this is doing what a ventilator will do for a person with a tracheostomy. But this is just a mask, okay? So this can use a nasal mask, a full face mask, or what they call nasal pillows. And those are those little things that just sit right under the nares and kind of poke up into the nares. Supposed to be a little bit more comfortable than a full facial mask, but I'm sure it depends on your person. So this is like our CPAP, right? This is what people can use at home when they are suffering from sleep apnea. We have CPAP or BiPAP. Uh, Basically, both of them are continuous positive airway pressure. They just keep everything open and moving. Remember that the alveoli stay open with this positive pressure. So there's pressure in the alveoli that's pushing from the inside to keep them expanded. So that's what this does for people, is keep everything expanded, all right? Keep it expanded and open. So this allows for inspiration and exhalation. Nothing's collapsing. This is talking about, this is box 7.1 straight out of our book. This talks about education for patients receiving home O2 because right, people can go home on oxygen. That's totally normal and fine. We see that a lot. I would say the biggest one is don't smoke while your nasal cannula is still attached to your face, right? I am not kidding. This happens frequently. Um, so that's some of the biggest things. Also, you're going to want to make sure that you have extra O2 canisters available. Don't let your O2 run out. There's a whole list here of stuff. You're going to want to tell visitors not to smoke around you. You're going to want to make sure, you know, if I have this long O2 cord, right, this tubing, because I like I like long O2 tubing because then I can walk around my house, do my things, not have to worry about it. But that is a trip risk, right? And if we're talking about the fact that a lot of times it's our older patients who are going to be on home O2, our fall risk is always a thing. So there's lots of things to think about related to home O2. This is a 2020 Joint Commission National Patient Safety Goal. This is a this is just about education for patient, family, or caregiver, about safety risks related to home O2. This one in particular talks about fire risk, making sure that you have a fire extinguisher at home, right? Because this is a real thing, not to mention a smoke detector, a home safety plan, which, you know, if the home catches on fire, how do we get out? What do we do? All right. This is about complications of oxygen therapy. So believe it or not, you can have oxygen toxicity. For right now, for the most part, we're talking about this related to our COPD patients. So we will talk about this when we get to COPD. But just know that oxygen toxicity can develop as a result of the administration of an O2 concentration equal to or greater than 50% over 24 to 48 hours. So high levels of oxygen can cause damage to the alveolar capillary membrane and inactivate surfactant production in the lungs. Loss of surfactant production can result in the walls of the alveoli sticking together and collapsing. Don't forget, surfactant is that stuff, it's like an ooze, but it works to keep the alveoli open. So if our surfactant goes away, this ooze is no longer there to help keep the alveoli open. It's almost like, kind of think of it like a KY jelly, right? Because then if we don't have surfactant, what happens is the alveoli collapse and they stick together. They don't have this lubrication keeping them open anymore, okay? So that's not good. So collapse of alveoli, it makes it difficult to reinflate alveoli. They can become filled with fluid or blood, which damages them. So then even let's say they're back to working again, right? They reinflate or whatever, but it can be a problem. They could be damaged and not function. So this can cause ARDS, which is acute respiratory distress syndrome. If you look at an X-ray with collapsed alveoli, it looks like a whiteout. Like you'll just see a big area of patchy whiteness, and that can be caused by the collapsed alveoli. So prevention of O2 toxicity is essential for patients who are receiving O2 therapy and can be facilitated by administering the lowest oxygen concentration to maintain the PaO2 within the patient's normal range. And remember, the PaO2 is the O2 level that we get from an ABG versus a pulse ox, all right? So what this is saying, like we talk about with everything, is we want to use the least of whatever, right? Least of meds to get our therapeutic response. Least of O2 to get our therapeutic response. You can overflood the body with O2. So delivering oxygen to patients with COPD may inhibit their stimulus to breathe. In patients with chronic lung disease, such as COPD, the stimulus for breathing is hypoxia rather than an increase in CO2 levels. The central chemoreceptors located in the medulla are normally sensitive to the increased arterial carbon dioxide. So that's the PaCO2 levels. Again, that's related to an ABG, as how we would get those levels. These receptors stimulate breathing and increase the respiratory rate. Patients with chronic lung disease have a gradual increase in PaCO2 levels. The problem with like COPD and whatnot is blowing off that CO2, not getting oxygen in. So the problem is they are over, they're holding on to CO2 when we should be blowing it off, right? And if we are holding on to CO2, we can't intake more O2. So we actually need less O2 because we're full of CO2, and we need to be careful about giving them too much CO2 or O2, sorry. You're going to be like, what is she even talking about? We need to be careful about how much O2 we give them because it can end up flooding the blood, and then it gets to the brain, and the brain thinks, oh no, they have plenty of O2, when in fact the person does not. All right, so it overcomes the system, and then the body thinks, oh no, we're breathing fine, when in fact we're not. So it overcomes that hypoxic drive and it messes up the brain. So we need to be very careful with COPD people about how much we're giving them. In the management of the patient with chronic lung disease receiving oxygen therapy, it is important to frequently assess the patient for changes in oxygen saturation, levels of consciousness, and rate and depth of respirations, as well as to frequently monitor ABG results. Oxygen-induced hypoventilation may be a concern for patients with chronic lung disease, but not treating the hypoxia is a greater threat to the patient. Withholding oxygen therapy can lead to greater hypoxia and can threaten life. Oxygen therapy is ordered at the lowest level of oxygen needed to treat hypoxemia. All right, this is called absorption. We have absorption atelectasis here, and then mucous membrane dryness. These are complications of O2 therapy. So absorption atelectasis occurs when high levels of oxygen are administered and cause the alveoli to collapse. The high levels of oxygen dilute the nitrogen that normally prevents the alveoli from collapsing and replaces nitrogen with oxygen in the alveoli. The high level of oxygen causes the nitrogen to be washed out of the alveoli. The oxygen diffuses from the alveoli into the bloodstream faster than it is replaced by inhaled oxygen, causing the alveoli to collapse. So with all of this, there's a whole bunch of things going on to keep everything open and moving, right? Everything's permeable. So all this really is saying is that the nitrogen gets flushed out by oxygen, but the oxygen diffuses into the bloodstream faster than we are inhaling oxygen. So without the nitrogen there, our little alveoli, they just collapse. Those little grapes, they just collapse in on themselves, and that is a problem because then they're not. We are dependent on the alveoli for the gas exchange, the O2 and CO2, in and out, the whole breathing process. So if those guys have collapsed, they're not breathing. We're not exchanging gases, and that's a problem. Mucous membrane dryness. Oxygen has a drying effect on the mucous membranes because the humidification of inspired air is lessened for the patient who is receiving O2 therapy. When O2 therapy is prescribed at levels greater than 4 liters via nasal cannula, humidification should be added. The humidification occurs when the O2 is passed through sterile water, causing bubbling in the container, and then goes through the tubing to the patient's mask or cannula. This process restores the humidity that is normally present in room air. We can also run into infection. Oxygen therapy can be a potential cause of infection. The equipment used to deliver oxygen, such as the humidifier, nebulizer, nasal cannula, any of the tubing or masks, can be a source of bacteria causing infection due to moisture that may accumulate. Healthcare facilities have protocols and or policies in place that state when the equipment is to be changed to prevent the cause of infection. Your hospital, wherever you're at, is going to have protocols related to when to change your tubing. Now, we really worry about bacteria, yeast, these types of infections related to home use of CPAPs or BiPAPs because people don't change out their tubing. They don't necessarily understand the seriousness of this. So it's a huge patient education thing to talk to somebody who's using maybe a CPAP at home about changing out all their tubing and all the things, right? Including the mask and all of that. This is talking about artificial airways. So first of all, we're going to talk about an endotracheal tube. So airway management is the first priority for clinical care and involves maintaining a patent passage for the inhaled air to move through the upper airways to the lower airways to achieve adequate ventilation. All that's saying is we want to make sure our person's breathing. Upper and lower airways can become narrowed or blocked as a result of secretions of foreign object or constriction of the airways. I'm going to throw in trauma too, right? Some sort of car accident or whatever. An airway that is not patent leads to oxygen deprivation. Without oxygen, cells begin to die and death of the patient may result within minutes. Through the use of artificial airways, the patient can be ventilated and provided with adequate O2 to maintain tissue perfusion. So this is just saying somebody cannot maintain their own airway. So we're going to use an artificial airway to help them oxygenate adequately. So the endotracheal tube, or the ETT, is an artificial airway used to maintain a patent airway when a patient is having respiratory distress. How about that? Distress. An ETT is a long tube made of polyvinyl chloride that is passed either nasally or orally through the vocal cords into the trachea and is placed just above the carina, the point where the trachea divides into the left and right main stem bronchi. The cuff, so the cuff on an ET tube is this inflatable balloon. We use air. But it's kind of like the same idea as like a Foley, right? We use an inflated balloon to hold stuff in place. So the cuff is inflated to prevent air from leaking around the ET tube to minimize the risk of aspiration, and it secures the ET tube in place. Sizes for adults range from 7.5 to 9.0 millimeters. Oral intubation is preferred over nasal intubation because it is quicker and allows visualization of the vocal cords during intubation, as opposed to nasal intubation, which is considered blind intubation because the vocal cords, you can't see them. So basically with an ET tube, we can go through the nose, we can go through the mouth. it passes through the vocal cords down to the point of the carina, which is where the lungs bifurcate into the left or right. All right. So the problem with nasal intubation is we can't see what we're doing. When we do oral intubation, you go in, you have a scope, you can kind of see what's going on, and it's a lot easier process. So if we are passing past the vocal cords, and I'm putting this tube down there, don't forget that anytime I place a tube anywhere, I run the risk of damaging the mucous membranes that are in the general area. Okay, so that is really one of my concerns. So to tube somebody, a certified nurse anestheticist, anesthesiologist, pulmonologist, intensivist, or acute care nurse practitioner is usually going to intubate people. That is special training to do that at bedside. Indication, so ET tubes indicated when there is upper airway obstruction, apnea, high risk for aspiration, ineffective airway clearance, or respiratory distress. These tubes can also be placed to deliver general anesthesia via an ET tube and may be required after the surgical procedure to maintain the airway. In all of these situations, there is a need for assistance to maintain adequate ventilation and perfusion. So basically, the patient's just not going to breathe adequately on their own. They need a little bit of help. They need an extra airway is what it comes down to. So nursing considerations. So this is going to be an interprofessional team approach. As nurses, if they're going to intubate bedside, so we make sure that people know about it. You know, if this is scheduled, you make sure people know about it. This may include anesthesia. It's going to be your pulmonologist, your healthcare provider, a respiratory therapist, maybe other nurses, right? We also have to think about the fact that we need to explain the procedure to either the patient or the family. We're going to be using O2, so we need to talk about that. We need to think about getting that intubation tray ready for the physician. We need to make sure our suction works. You know, if we're doing this bedside, which you can, you need to make sure that all your stuff is working. O2 is working, suction's working. We have all the things available. Could this person crash on you? Absolutely. So you need emergency, like your code cart, your emergency equipment at bedside. Different physicians like different meds. You're going to get to know about that when you are preparing for bedside procedures. During intubation, the nurse coordinates the care of the patient. Nurse continuously monitors the patient. This is going to include, you know, your vitals, your pulse ox. We're going to be watching for signs of hypoxia, dysrhythmias, and aspiration. If intubation takes longer than 15 to 30 seconds, the intubation needs to stop. Then we're going to manually ventilate our patient, which is going to help prevent hypoxia or cardiac arrest, and then a second attempt at an ET tube can be initiated. It is often the responsibility of the nurse to ensure that the procedure is stopped in the event that the attempted intubation exceeds 30 seconds. So we're a timekeeper, right? We're watching to make sure that this does not exceed 30 seconds. And then we're going to be like, stop. We need to super oxygenate our person. And then they can do another try. Once the patient is intubated, endotracheal placement is verified by an end-tidal CO2. Indicating CO2 is released in expired air from the lungs. So this is making sure that that ET tube is in the lungs. We want to see CO2. If the tube is inadvertently placed in the esophagus, the end-tidal CO2 is negative. Okay, so our expiration of CO2 tells us that it's in the lungs, we've placed it correctly, and life can go on. We also look for symmetrical chest rise and fall with ventilation, equal and bilateral lung sounds. There's the barking. I told you would happen. So Let's see, right main stem bronchus intubation occurs because the right bronchus has a lesser angle to the trachea and is often wider than the left bronchus. With right mainstream intubation, the ET tube needs to be repositioned and reassessed for correct placement. So it's easy for it to go into the right bronchus because of the way the lungs are set up. So we're going to inflate the cuff with 20 to 25 millimeters of air. High cuff pressures can result in ischemia to the surrounding tissue. So you don't want to overinflate the cuff because you can cause damage. Low cuff pressures, then if the pressure in the cuff is too low, then the person can aspirate secretions. Maybe ventilation doesn't get delivered effectively because that air then is passing past that cuff. It's going around it. We don't have a blocked off airway for our artificial airway to sit in. Okay, so we're losing whatever we're pumping in. All right. Also, if your cuff is not inflated adequately, it's less stable. Your ET tube is less stable. And anytime you have an unstable ET tube, that can move around. First of all, it can move out of place, which would be our biggest concern, but also it can cause damage. So there's a lot of considerations. ET tubes are, there's just a lot of considerations. These people are going to be in your ICUs. You are not going to have someone with an ET tube on med-surg. You're just not, because there's too many possibilities to go wrong that can lead to death of the patient. So when we're placing an ET tube, our doctor may want a paralytic. That's scary. That takes a lot of monitoring. We need to make sure our person gets through the procedure, that they're breathing adequately afterwards. Also with an ET tube, our person can remain sedated. That may be a possibility. So then we're going to have to do all the things related to sedation. But again, that's ICU and all that monitoring. And then our person is going to be on a ventilator. So really, in our big hospitals, respiratory therapy manages our vents. If we as nurses in the big hospitals were to touch a ventilator, our respiratory therapist would probably shoot us from across the room, right? That is not our domain. But I will tell you, families will look to you to ask about what is going on with the patient related to the vent. Now, best case scenario, you grab your RT can talk to the family. Cool. But what if you can't find your RT? What if your RT is in a procedure? What if this family is particularly demanding and wants answers right now, right? And we just sound smarter when we can talk to something. So even though, for the most part, ventilators are not our deal, we still want to know something about them, especially if you end up working for a hospital or a floor, a unit where you have a high vent population. All right. So, all right, back to ET tubes. So documentation, nurse documentation, this is of course what we do related to the intubation procedure. So we're going to do a complete assessment of the patient. We're going to talk about what size ET tube we use, the position, the location. There's going to be centimeters marking at the lips, teeth, or gum, right? So kind of like an NG. You know how we mark with an NG where the tube is sitting? Same deal with an ET tube, okay? We're also going to document the vent settings. Your respiratory therapist will be documenting the vent settings as well. And then we're going to document the patient's response to the procedure. We are going to be in charge of proper ET tube management, patent airway, monitoring the patient for complications. Our book says maintaining proper cuff inflation, but in our big hospitals here, that's going to be our RTs. Now, you could work home health and have a patient on a vent, and guess what? That's all you, right? Or you could work a rural hospital And that may be all you. So I'm not saying that we won't be doing this. I'm just saying that if you go to work at a larger hospital with respiratory therapists, a lot of this is what they do. Okay. Um, so we may be providing oral care and suctioning, definitely. We're going to ensure correct tube placement, that ET tube stays where it's supposed to be. We're going to monitor O2 levels, right? All of that stuff. Our person may need respiratory treatments. Again, probably RTs, but maybe not. We may need to get ABGs on our person. ABGs give a little bit more precise reading of oxygenation status, all right? So when you have someone on ventilation, you're going to be running ABGs. And then we call it weaning, but as you take somebody off of mechanical ventilation, where maybe the vent is breathing less for them or not breathing at all for them anymore, you're going to monitor ABGs because we want to make sure that the person is adequately oxygenating. My hospital respiratory therapist got ABGs, lab would call, it went straight to respiratory. But again, going to depend on where you work, right? And what your protocols are for. Communicating with somebody on a ventilator or with an ET tube. This could be difficult, right? So they have this tube down their throat. Maybe they're not fully sedated. So maybe they can write on a whiteboard. We need to think about that. I know from experience, I swear, I mostly dealt with people with tracheotomies and ventilators. But with a trach, you can't talk either. There's nothing there. And people want to mouth words to you. And it's so frustrating because some people you can understand, but for the most part, it's very difficult. So we need to try to help them with communication and reduce their anxiety as much as we can, right? So a lot, like if they can't use a whiteboard, maybe they're not strong enough to write, a picture board, gestures. Again, lip reading. Good luck with that, but sometimes it works. We're also going to want to explain to our patient what is going on. They may come out of sedation and be like, what the heck, right? We may bring them up out of sedation. So they may not know what's going on. Let's see here. So our person can't swallow, right? They've got this ET tube down. If a person has an ET tube and they're on a vent, you're going to see a closed suction system. We will talk about that in lab. Just remember that every time we suction, when we suction, we close off that airway. So that is going to increase risk for hypoxemia and bronchospasm. Suctioning can be irritating. So when we cause bronchospasm, our person may start coughing. We call it bucking the vent, which is where they're breathing against what the vent is trying to provide for them. And sometimes we end up sedating people related to this bucking of the vent, right? Because we need the ventilator to be able to do what the ventilator needs to do, and we need your body not to fight against it. So if your person is having repeated bronchospasm and they're coughing and bucking the vent, that person may be a good candidate for some sedation, right? When we suction ventilator patients, it's going to be dependent on how their secretions are, right? So we've stuck a tube down somebody's throat. So it's reasonable to assume that the body is going to react with kind of an inflammation process, throw some fluids at the situation, because the body is going to be like, there is something foreign down our throat. I'm going to try to flush it out. That's the body's first reaction to anything foreign in the body. So it's going to make sense that your person's going to have some secretions. Now your person may have pneumonia. They may have other things going on. So we're going to look at, we call it the tenacity of the secretions, which means how thick our secretions are. We use the word copious when we have a lot of secretions. We call it minimal and thin when maybe it's a little bit, maybe it's just like saliva, so it's thin. It's not all gross and slimy and sticky, right? So there's lots of words related to how we describe secretions related to our trach ET tube ventilator patients, all right? You're going to hear pulmonology and your RTs use this vocabulary. Complications of an ET tube, aspiration, infection, and then your person may decide to extubate themselves, or maybe we're moving them to MRI and the ET tube extubates, right? That is a problem. Because remember, this tube was breathing for them, right? So those are all the things we need to keep in mind. A tracheostomy. So we can't keep a person with an ET tube forever. It's not safe. So if our person is requiring mechanical ventilation for longer than 17 to 14 days, so 1 to 2 weeks, we're gonna want to start talking about placing a trach. It's safer, it's less damaging. The person can go on as we wean them off the ventilator to, they could just be on O2. They can talk with a trach eventually. You can eat with a trach. You can do all the things. So if a person is still needing respiratory support, airway support, longer than 1 to 2 weeks, we really would like to change over to a tracheostomy, okay? It's just a better outcome for people. There's less risk involved, and it's a nice, smooth process. So a tracheostomy is indicated to provide a stable airway in patients who require long-term ventilation. You can live with a trach. You can go about your life. When I worked in home health, 2 of the little kids I had tracheostomies. They went to school, we went to the park, we did all the things, right? One of the little guys was able to eat. You can put, there's different caps you can use on tracheostomies. One thing is called a Passy-Muir valve, and that has a little vibration. It has a little piece of paper in there. It kind of works like a harmonica, to be honest with you, because it vibrates. Has a little piece of paper in there that vibrates and makes the noise. So a Passy-Muir valve you can put over a trach, and then the person is able to vocalize because it vibrates for them. You can also fully cap a trach. Maybe a person doesn't need O2 or ventilator support during the day, so you can cap the trach. The person can eat, the person can do all the things, and goes about their day. So there's all sorts of things. There's these little there's these barrels that you can put on. Maybe a person can't tolerate a trach. Maybe they still need some O2 going in and out of that tracheostomy, but at room air level. So the barrel allows for humidified room air to go in and out and pass through that trach. So there's all sorts of options for people with tracheostomies. It's a very livable condition, even though it may seem daunting at first, but it's a very livable condition. There's different sizes of tracheostomies. That's going to be based on your person. There's different types of trachs. There's let's see, a Bonova. That's the wrong name. But it is a trach for like our bigger people. Our bigger people tend to have bigger necks, right? So maybe a trach is normally like this. Well, we need something that extends because these bigger people have a lot of adipose tissue in the neck region. So it's a Bavona, sorry. Bavona is the one for the bigger people. And so there's all different trachs. Your facilities, depending upon manufacturer of trach, is going to depend on what sizes your trachs are. There's different manufacturers of trachs. They're not all the same size. Like a size 7 in one manufacturer is not a size 7 in another. Also, your inner cannula. There's the trach itself, and then there's the inner cannula, which is a piece that fits inside the trach. those are different sizes as well. In lab, we're going to talk about cleaning or replacing an inner cannula. The benefit of an inner cannula is I can remove that inner cannula that may be full of disgusting phlegm without having to take out the whole thing and risk losing my airway. All right, but we will talk about that in lab. There's a fenestrated tracheostomy tube. Fenestrated just has little holes in it that allows a patient to speak. We have cuffed and uncuffed. Again, the cuffed works to hold it in place, keep things from passing past it. There's all different options with trachs, all right? So there is that. All right, moving on. This talks about tracheostomy care. Again, likely going to be your respiratory therapist, but it is within our scope of practice. So tracheostomy care provided at least each shift or as needed. And it's going to be dictated by your facility's policies and protocols. So this is to make sure that that trach remains patent. If your person has thick secretions, those secretions can definitely close off that trach, all right? A complication is decannulation. That means that tracheostomy tube has come out. That is a big concern, especially 72 hours after the surgical placement of a tracheostomy tube. That's because the stoma has not matured. It's still moving around, you know, there's a less stability there. Our biggest concern is that if that tracheostomy comes out, we will not be able to get it back into that same tract. There's also stuff called a false tract, where that means your tracheostomy kind of shifts, and even though it looks like it's still in, it has shifted, and it actually, the little opening of the tracheostomy can be kind of lining up with or pushing into mucous membrane and is not actually ventilating your person. So even when our trach appears to be in place, we need to be monitoring our person, looking at their O2, watching them for signs of hypoxia, because we never want to trust, don't ever trust that your trach is just fine, okay? At the bedside of our trach patient, you keep not only a tracheostomy tube in the same size that your person has, but also one in a lower size, a step down. Because if that trach comes out and we can't get the same size back in, sometimes it's easier to get one smaller back in. All right, so that should always be at your bedside. Your respiratory therapist is going to make sure that that happens. But as nurses, guess what? We should be making sure also, all right? Because ultimately we're going to be asked why that smaller trach tube was not at bedside, or why even an extra trach tube was not at bedside. This is a picture of an ET tube versus a tracheostomy, so you can kind of see what those two look like compared to each other. This talks about incentive spirometer. I know that you guys did talk about this in fundamentals. You know, you want our patients to use 5 to 10 times per hour while awake. If you do not remember the steps related to using an incentive spirometer, please review that, all right? This is box 7.2. This is talking about how to use our incentive spirometer. So again, if you don't quite remember, just need a refresher, box 7.2 for incentive spirometer. This talks about chest physiotherapy. That's the clapping, right, on people. So chest physiotherapy is ordered when the patient requires assistance in removing pulmonary secretions. CPT consists of percussion, vibration, and postural drainage. Postural drainage just means, like, I may tip you with your head down because, you know, gravity can work for us or against us. And we're talking about wanting secretions to drain. So if I tip your head down and I'm doing percussion on your chest and vibration to loosen up those secretions, I then want gravity to be my friend and move those secretions towards your mouth, throat, all of that. So then hopefully the idea is that you can cough up those secretions. We may need to suction somebody after CPT. We also, if their cough is not effective. Also keep in mind with chest physiotherapy, we're pounding on somebody's chest, right? I mean, it's controlled, it's not causing bruising, it's not an abusive situation here, but it can be disruptive. So CPT is ordered 1 hour before meals or 3 hours after meals. We do not want our person puking and then potentially aspirating, right? We also may do a bronchodilator before CPT. That allows for bronchial dilation, so for everything to open up, and hopefully our person's breathing a little better. And then, like I said, we may use postural drainage, which just means tilting our person in different manners to get those secretions to come out. Keep in mind that we can train people at home to do this. We can train family to do CPT at home. So if you have somebody, like if we're talking cystic fibrosis patients make a really thick secretion. It's a debilitatingly thick secretion, right? So they're definitely going to go home and family is going to have to do this, or a caregiver, and we just train them. Keep in mind, it's a cupped hand, right? We're not slapping someone open with an open hand. It's like this. So it's not an abuse situation. Okay, do not take your anger out during CPT. This is from our book. This is showing some of the positions that people can be in. One of the other things with CPT, if our person is wearing normal clothing, you don't want to do any pounding over, buttons or zippers or anything like that, because we don't want to cause skin damage, right? So ideally, t-shirt, workout pants, something like that, no buttons, no zippers, nothing where we're concerned. Also, you want to be aware of the edge of the rib cage. Because we don't want to be pounding on organs, right? We don't want to cause damage. This is over the rib cage, so we want to be aware of those boundaries. These are nebulizer treatments. Again, nebulizer treatments are something that people can do at home. In your bigger facilities, your RTs are going to be giving your nebs, but nebs are within our scope of practice. So these are prescribed by healthcare providers. The benefit, these are usually like bronchodilators. They could be steroids, mucolytics like Mucomist. Those are thinning agents. So if you have a really thick sputum, you could use something like Mucomist to reduce those secretions and whatnot. So just remember that the benefit of this is it's essentially like focused treatment, right? Because our problem is in our lungs and our airway, and with a neb, we can breathe that right into where our problem is. So it can help with inflammation of the bronchioles. Like I said, it can thin secretions. It's going to open up our airways if we're using a bronchodilator. So what we do, if your RT does not do this, if we are doing this, we would listen to breath sounds before and after, right? Look at O2. Because we want to know, that is how we're going to know if this treatment was effective. Is our person breathing better? Now, if we're using a bronchodilator, don't forget that your heart rate's going to be up, just as response to the bronchodilator, right? But we're going to do a before and after, okay? Just like we do with pain, we're going to assess before, we assess after. That is how we determine if our intervention has been effective. This is talking about mechanical ventilation. So there are a bunch of slides in here on mechanical ventilation. I don't want you to memorize them. You don't need to memorize them. Mechanical ventilation required when a patient cannot maintain adequate ventilation and or perfusion. So they're not breathing well on their own. Maybe they cannot maintain their airway. Sometimes things want to collapse. In the case of motor vehicle accidents, sometimes things can be crushed. This could all be crushed. They may not be able to breathe. So we need to use an ET tube or a trach and put our person on ventilation, right? So this is help for people who cannot maintain their airway. So this could be acute respiratory failure, heart failure, even our COPD people. You want to, COPD though, once you put them on a vent, it is very, very hard to get them off. Somebody who has gone into cardiac arrest, maybe a drug overdose, respiratory depression, spinal cord or neurotraumas, right? So the goal of mechanical ventilation is support the patient until the underlying pathophysiological process is corrected. So basically whatever's going on with them gets resolved and we can help wean them off the vent. Vent is not a cure, it just helps support the patient with their breathing. Once the underlying condition is corrected, the vent can be discontinued. Patients who cannot support their own vent needs or who cannot maintain optimal oxygenation may require mechanical ventilation on a permanent basis. This may be, our quads, depending upon where that injury is, you may not be able to breathe. So you may be on a vent for the rest of your life, right? Role of the nurse includes providing continuous monitoring, assessment, prevention of complications, monitoring the equipment for any problems, and then providing emotional support to the patient and family. Even though the patient can go home on a vent and go out and about, right? You can do all these things, but imagine if this comes out of nowhere, like related to a motor vehicle accident or some sort of accident. This can be very disheartening, right? This certainly is not the life you pictured for yourself. So this talks about negative pressure ventilation. This is a non-invasive mechanical vent used for patients with respiratory disorders or associated with neuromuscular disorders. So that means something is not allowing us to breathe. Remember, to breathe, we not only need the lungs to do their thing, but we need like our core muscles to be able to work. Our diaphragm is heavily involved in breathing. So if we have some sort of neuro or muscular dystrophy process going on, disorder, where our muscles are no longer strong or our brain is no longer telling those muscles how to react, we may need help with breathing. It may not be just a lung thing, right? So there's a lot of people out there who may need help with this. So during spontaneous breathing, negative pressure is created when the thoracic cavity expands, causing intrapulmonary pressure to drop and air to flow into the lungs. This type of ventilation is similar to natural respiration. So you can see this guy with this chest cuirass ventilator. I have never seen this. This is similar to like how the old iron lungs used to work. If you don't know what an iron lung is, Google it, right? It's what we used to have to use with like polio kids and stuff. So an iron lung you used to go in, I would almost compare it to what an MRI looks like, not as thick, but you go in, your whole body goes in, and this thing breathes for you, and you were stuck in there for life. At least this chest cuirass ventilator, like he's sitting in a chair. Not that it's amazing, but he looks comfortable, right? So iron lungs, not really used anymore in modern medicine. Just out of curiosity, I Googled it. It's this chest cuirass ventilator is what has taken the place of the iron lung. And again, I've never seen this chest cuirass ventilator in use, but you might, who knows? And then our mechanical ventilation is positive pressure ventilation. So this is just needing an ET tube or a trach to use. It's our vent, right? Our ventilator. So these are different mechanical ventilator settings. Again, you don't necessarily have to memorize these, okay? First of all, this is for the most part, critical care stuff. Now, if you work in home care, you may get a person on a ventilator. So this would be part of your life. But these are some kind of basic terms. FiO2 is the fraction of inspired oxygen. You know, we talked about that before. That is how much O2 you're actually getting, and it takes into consideration that you're not receiving pure O2, right? When you're on nasal cannula and we say you're getting 2 liters, you're not getting a full 2 liters because it's mixing with outside air. Our rate is just our breath rate. Tidal volume is the amount of preset air that is delivered with each breath. So that's a setting, okay? That's a setting on your ventilator. The flow rate is a volume of gas per minute, okay? So what's the flow rate? How fast is that oxygen being released, I guess. I don't know. I'm not explaining that very well, but it's the flow rate of the O2. And then the PEEP, positive and expiratory pressure. So normal PEEP is 5. PEEP is what keeps our alveoli open, all right? So PEEP is pushing against that alveoli, keep the alveoli open and inflated. PEEP of 5. Now, when our person is on a vent, they may need more PEEP to keep the alveoli open, dependent upon their disorder, whatever's going on with them. So I would say when I worked with vent patients, like PEEP of 10, PEEP of 8, maybe PEEP of 12. Okay, was about where we saw our vent patients, all right? So remember, PEEP of 5 is what I'm sitting here breathing normal room air. I have a PEEP of 5, okay? That's normal. Now, when we had COVID, we were seeing people on a PEEP in the 20s, like high 20s, which is just crazy town. And the problem is, PEEP is pressure pushing against the alveoli to keep them open. You can rupture alveoli. So that was another problem associated with COVID, is that they were needing such high PEEP to keep these alveoli inflated, but you actually run the risk of exploding your alveoli. Isn't that crazy? So hopefully we don't see that again, but if you get COVID people on your ICU unit, you may see some crazy town PEEP being used. So FYI. These are vent modes on our next slide. Do not memorize this. Just know that a vent can either fully breathe for a person, it can be doing all the breaths, right? It's set, it's breathing on a set rate, it's doing all the things. Or you can set a vent to where I'm doing most of the breathing, but let's say I miss a breath or I don't breathe in deeply enough, then my vent will kick in and breathe for me, will oxygenate adequately for me. So there's all different modes on the vent. It depends on what's going on with your person. It depends on how strong they are. Usually if you're weaning somebody, a person is going to start on full support. So the vent is doing everything for them. As we wean somebody, you get down to like pressure support and assist control, where the vent is kind of waiting for us to breathe on our own, right? And if it doesn't, it'll kick in. So just be aware of that. Don't memorize these. This is a safety alert. This basically talks about, you know, vents have alarms on them. Don't ignore them. When a vent alarm goes off, something is going on. All right. Our first thing to do is to make sure that our person is okay, that they are oxygenating adequately. We don't want an alarm to go off and we're in there checking on the machine. We want to go in and check on our patient. We may need to bag them, right, to provide adequate ventilation. There may be something wrong with our ventilator as a machinery versus our person not breathing adequately. So again, just be aware that if our person's not adequately ventilating, our problem, our resulting complication is a noxic brain injury or death. And I can tell you this happens. Okay, this is a real thing. It's a problem. So don't ignore your alarms. Don't wait for RT to get it. Go in and check on your person. These are complications related to ventilators. Um, you can have hypotension related to changes of pressure in the chest cavity, infection, always infection. We have an open hole to the airway, bypassing like all the little cilia, all the checks and balances, bypasses the tonsils, all these checks and balances to that are there to catch bacteria and viruses before they get to the lungs, right? Think about that. We have a hole here. So if we have a trach, it bypasses all this stuff. If we have an ET tube, we're bypassing all this stuff. So infection is always a thing. Um, Barotrauma is related to the positive pressure being used in the lungs, which can cause the alveoli to pop, like we talked about, related to our COVID people. And then aspiration. Again, we're kind of providing a straight shot to the lungs. So we're always worried about our people aspirating. So we want to suction as needed, and also oral care. One of the biggest ways to prevent infection related to ET tubes or tracheostomy is oral care. A lot of times it's going to be based on your hospital policy, but they will use like a chlorhexidine mouthwash, and you get these little spongy toothbrushes that hook to suction. And so you can go in there and clean out the mouth, because not only do we have normal flora, but we're in a hospital. My mouth's hanging open. I have this proliferation of all these things now. So we definitely want to get as much of that bacterial growth out of there as we can, because then if I do aspirate, maybe the less bacterial flora gets aspirated if my mouth is as clean as I can make it, right? Also, it just helps people feel better. We want to keep our head of bed elevated to 30 to 45 degrees. That too is related to risk of aspiration. Um, let's see, what are the other things we're going to do? If our person's on sedation, believe it or not, they call this a sedation vacation, and that's literally where we let our person come up out of sedation, and then we kind of assess their readiness to wean. How are they breathing? Are they fighting the vent or bucking the vent? Do they seem stronger? You know, what's going on with our person? So they call that a sedation vacation. Um, and don't forget, excessive sedation can lead to respiratory depression, right? So we want to take that into consideration as well. There's also peptic ulcer disease prophylaxis. So our person is going to be on PPIs to reduce gastric acidity, because we don't want our person having reflux and those acidy gastric juices coming back up and causing problems in the esophagus. It can literally burn the esophagus. You can end up with ulcers. You can end up with ulcers in the stomach, ulcers in the esophagus. It can lead to GI bleeding. So our person's going to be on a PPI. Now remember though, when I kill off the acid in the stomach, I put my person at risk for C. diff, because acid in the stomach is one of the things that keeps C. diff at bay. So we need to be cognizant of that. If our person is not moving, they're at risk for DVTs, deep vein thrombosis. So we're gonna want to make sure they are on anticoagulants and have sequential compression devices. So SBDs on the legs. The SBDs use pressure to keep all of that moving. And then the oral care with chlorhexidine. This is assessment of respiratory function. So this is starting at the beginning. So history of present illness, obviously, right? And then we're going to want to know what factors exacerbate or improve their symptoms. We're going to talk pain, cough, changes in weight. You know, when we talk tuberculosis, unexplained weight loss is a big deal because, and remember, people usually are going to choose breathing over eating. So when people can't breathe, especially chronically, we look for these changes in weight because while you're chewing, you're not breathing. So you may not be eating all that much because you can't breathe while you're doing so. And we're going to look to see if they have dyspnea. Factors that exacerbate or improve symptoms. So this could be like exercise. One of the things we would worry about is what if just walking exacerbates your symptoms, right? Like if I tell you, well, when I go hiking and I climb this mountain and I'm sort of out of breath when I get to the top, that might be expected, right? But if I tell you, I walk from my office to my car and I can't breathe and I don't go up any steps or anything, right? That seems like a bigger problem because we wouldn't expect that to be happening. Um, don't forget that when our respiratory system is being strained, it also puts a strain on our cardiac system. And so our problems, maybe they're respiratory, but they could be cardiac as well. Pain, people may be having pain. Maybe it's pain just from chronic coughing, right? If you've ever had a cough, an extreme severe cough, your chest hurts. Um, Let's see, changes in weight, we talked about that. Dyspnea, so shortness of breath. We want to know how short of breath they are. And we do actually use a 1 to 10 scale. 0 would be no shortness of breath, and then 10 is the worst. So even though it's subjective, we want them to rate their dyspnea for us. And maybe if they say dyspnea is more extreme when I'm working out, well, then on 1 to 10, what is your dyspnea when you're working out, right? We're also going to be wanting to look at posture. Sometimes when people can't breathe, maybe they do that tripod positioning where the elbows are on the knees. You're going to want to watch them breathe. Are they using accessory muscles to breathe? Are they pulling? Can we see them, can we see this pull in when they're breathing? Are they gasping? This is a safety alert related to TB. One of the things we really associate with TB is hemoptysis, which is bloody sputum. Now, bloody sputum, never good. Never, never, never good. Doesn't indicate TB right off the bat. We're still going to be doing some testing. Could be cancer, right? Could be cancer, could be irritation, could be GI. But hemoptysis, bloody sputum, think TB, never good. Um, Also talks about low-grade fever, weight loss, and night sweats. So if your person comes in and has these signs or symptoms, we are going to want to rule out TB. And if we are even remotely suspecting TB, even remotely, we want to make sure we throw our person on into negative pressure isolation. All right. We want to protect all the other people in our facility from that TB. This is talking about what we talk about with a health history. Take a look at this slide. This is slide 38. Pretty much all the stuff that we normally talk about. Don't forget when we're talking about respiratory, we want to make sure we ask about smoking history and then recent travel because TB is not endemic to the United States, but TB is endemic to other parts of the world. And there's other respiratory things that people can come in contact with. So you want to make sure to ask about travel. And then it's all the usual stuff. Assessment of respiratory function, our physical assessment, normal things, inspection, vitals, palpation, percussion, and auscultation, all the normal stuff. We're going to want to think about level of consciousness as well, because if our person is hypoxic, the brain can be short of oxygen. So, and anytime the brain is short of oxygen or has a buildup of CO2, you get changes in level of consciousness. And people with buildup of CO2, they are loopy. These are your people who are going to be like, the purple monkey is talking to me and he's sitting on the ceiling. It's not normal. It's not normal like saying it's 1952 when it's, 2025. This is a weirdo, loopy confusion that you see. So just be aware, throw in level of consciousness with that. This safety alert on slide 40 is talking about the signs and symptoms of dyspnea. One of the biggest things is unable to speak in full sentences, only able to say a few words. That's a big red flag. Use of accessory muscles. Use of accessory muscles is bad because our accessory muscles normally are not used to breathe, right? So the problem is accessory muscles can wear out, and then we are worried about going into respiratory arrest as the body gets tired. So the body should not be thinking about breathing, right? It just happens. It's brainstem activity. We don't have to think about it, we do it. So when we're starting to use accessory muscles, basically the body is having to work at breathing. And our biggest worry is that the body's going to get tired and go into respiratory arrest. We're going to, of course, listen to lung sounds, look for retractions. Is your person pulling when they're breathing? Abnormal percussion and cyanosis, right? Does our person look blue? That's a red flag when your person looks blue. This is talking about lung sounds. Know these: bronchial, bronchovesicular, and vesicular. Bronchial, neck and trachea, okay? Bronchial sounds are bad because things can be closing off. When bronchial sounds turn into stridor, that means that it's like a whistle, right? So our airway is closing down, inflammation's taking over, and that air is squeaking through that bronchial airway, right? So bad. But bronchial, neck, and trachea. Bronchovesicular, kind of up here, upper chest by the clavicles to shoulders, right? Vesicular, down towards the bottom, all right? Know what these are supposed to sound like, know where they're located. Here's some breath sounds. Rhonchi, sounds like snoring. Wheezing, squeaky, musical. We kind of associate it with asthma, right? Wheezing, asthma. Squeaky and musical. Stridor is high pitched. Things are closing off. We associate this with laryngitis, epiglottis, and allergic reactions. And that's because the swelling is shutting down our trachea. We are not going to be able to move air pretty soon. So stridor is literally air, high pitched, trying to get through those closing airways, okay? Wheezing, squeaky, musical, associated with asthma. This talks about respiratory monitoring. So this is our pulse ox consideration, all right? So the pulse ox, like we think about it looking at the monitor and it tells us like pulse ox 92, right? But keep in mind that the pulse ox uses wavelengths of light to measure the saturation of hemoglobin with oxygen. So it's non-invasive, right? And it gives us the oxygenation status. And it's pretty accurate, right? This is pretty accurate. So we can place the pulse ox on usually a finger, but you can also use ear, toes, and forehead. Normal pulse ox is between 95 to 99. If our pulse ox is at 100%, it's no longer reading accurately because it is not calibrated to read above 100%. So we may have an oxygen saturation above 100%, but a pulse ox cannot read above 100%. So it's just going to tell you 100% because it's capped out. So the safest is to keep your person at 99 because then your pulse ox is still reading. It is truly reading the oxygen saturation of the blood. At 100, it's no longer reading. It's just like I'm at my highest level. This is all I can do. It's not reading anymore. But at 99, you're still getting an accurate level. So pulse ox readings may be inaccurate if there's poor perfusion in the extremity being monitored. We talked about with our autoimmune stuff, people who have Raynaud's, if they have Raynaud's, if they have fake fingernails and nail polish on, you may not get accurate readings because related to not being able to read perfusion levels. Okay. Also, poor perfusion can be caused by hypothermia, right? They're cold, shock, cardiac arrhythmias, carbon monoxide poisoning, edema, peripheral vasoconstriction, which is our Raynaud's, tourniquets, and inflated blood cuffs, right? Because all of that stuff is cutting off the flow of oxygenated blood. So that can affect all of this. Nursing complications. So we just want to confirm accuracy of our pulse ox, right? By doing this, we can look at the waveform. So normal sine. Notice our waveform kind of looks like a normal sinus rhythm, all right? Kind of looks like normal sinus rhythm. Notice that low perfusion looks similar to asystole, right? Asystole is a straight line. Look at low perfusion here, right? Just little straight line. This is what it looks like with noise artifacts. So we're getting, we're reading something that doesn't have anything to do with perfusion. And then motion artifact is related to our person. Maybe they talk with their hands and, you know, their O2, their pulse ox is on their finger and they're all over the place. That's what this is going to look like. You want to know what a normal pulse ox waveform should look like. All right. So this is slide 43. Take a look at that. Respiratory monitoring, capnography, and capnometry. So capnography continuously monitors the PaCO2 in the airway during inhalation and exhalation and provides a written tracing. Devices can either be mainstream or sidestream. Mainstream measured directly at the source with the sensor in the airway circuit. So this is going to be like in your vent. This requires the patient to be intubated with an artificial airway. Side stream technology diverts the exhaled air from an artificial airway or a face mask to a sensor device. So if your person's on a vent, the capnography is going to be part of the ventilator or part of the ventilator tubing and all of that that connects to your person, and it's going to be reading the CO2 exhalation. All right. Capnometry measures the amount of CO2 exhaled without continuous tracing. So this is going to be like a point in time level. So it's a one-time CO2 reading. We're going to look at this when we're looking at end tidal CO2, right? We're looking at the buildup of CO2. We are maybe testing things to make sure that they're in the lung. The reason we care is that abnormal capnography and capnometry indicate dysfunction of the respiratory system and expelling CO2. And remember that if we have trouble expelling CO2, then our O2 is not going to have any place to land. So without getting adequate CO2 out, O2 doesn't have any place to go. And buildup of CO2, we don't live off CO2, we live off O2. So buildup of CO2 is going to cause all sorts of problems, one of which can be obviously changes in level of consciousness. So nursing implications, capnography. Let's see. If we're using this device, it's going to be utilized on a mechanically vented patient. So care must be taken not to disrupt the artificial airway, the tubing or the device if we're using this. Because we want it to give a true reading, right? You need to make sure that capnography equipment is calibrated and zeroed, all right? Again, this is likely going to be your RT. Capnometry typically utilized to confirm endotracheal tube placement after intubation. This device will show a color change to blue, indicating presence of CO2. It's going to give you a reading. of where your CO2 is. And there's safe levels and unsafe levels, right? Also, when we're using an ET tube, we can confirm by auscultation and chest x-ray. Chest x-ray is going to be better than auscultation. Continuous capnometry or monitoring of the end tidal CO2 is also recommended for use during cardiopulmonary resuscitation to evaluate the effectiveness of compressions. If our compressions are not compressing enough, we're not going to be pushing out that CO2. And if we don't push out the CO2, the O2 has no place to land. Okay, so you may measure your CO2 just to make sure that somebody is doing adequate compressions. When you practice compressions, you may practice with and measure CO2 levels just to see what it looks like. End tidal CO2 values between 10 and 20 indicate adequate compressions. This is respiratory monitoring. So these are just some of the things that we are going to do related to making sure that people are breathing okay. So we may do a sputum analysis, right? Do we have any microbes growing? You can collect a sputum analysis from a trach. Ideally, we want to collect a sputum culture in the morning. And you can also clean the mouth before you collect a sputum culture, because we don't want to culture normal flora, and we definitely have normal flora growing in the mouth. So you actually can clean out or rinse whatever the mouth before you collect a sputum culture. Patients with an ET tube or tracheostomy, you can have the sputum culture collected by suctioning the airway. And then we just put our collection into the sterile container, just like you do normal. Nursing implications, patients who require suctioning for collection of a sputum sample, we may have to hyperoxygenate them before we suction. And this is going to depend on how well they're breathing on their own, right? Hyperoxygenating, if your person is on a ventilator though, you just push a button, hyperoxygenate, wait a few seconds, right? And then collect your sputum sample. Also, you can, we could bump the O2 if our person is on a trach collar. You can bump your O2. You can use an ambu bag to give them a few pumps of just pure oxygen, right? Our oxygen's at 100%. So there's a couple ways you could hyperoxygenate. If your person's doing fine, you may not even need to hyperoxygenate. It depends on your person. So while we're collecting a sputum sample though, we're going to be monitoring our person, respiratory rate, heart failure. If our person shows any signs of distress, we stop. We put them back on the vent, we hyperoxygenate, do whatever we need to do to bump their O2 back up. They may also do a pulmonary function test. So pulmonary function tests evaluate lung volumes and capacities to determine the functioning of the lungs. So there's a mouthpiece, the person inhales and then exhales into the mouthpiece. During the test, the patient is given instructions to alter their breathing patterns. So that allows for different tests to be obtained. Before the test is started, they do a baseline reading. And this is going to be part of the baseline is based on whether you're male or female, weight, height, and smoking history. And then what they do is calculate where your norm should be. And then they compare that to what they actually find. So significance of abnormal values related to a pulmonary function test. These are discussed on page 23.7, and it just talks about different disease processes and whatnot can be going on. Patient preparation. So the patient, this is kind of interesting for a pulmonary function test, and this is education that we would be providing. So the patient needs to refrain from smoking and eating for 8 hours before the test. 8 hours before the test, no eating or smoking. Also, do not take any bronchodilators. We want to see how the person is breathing without help. So no bronchodilators 4 to 6 hours before the test. Um, and then the person administering the test should provide clear instructions to avoid unnecessary repetition. So we don't want to have to do the test again, right? And then, of course, if our person has been off their bronchodilators for 4 to 6 hours and we're asking them to do breathing exercises and stuff, we're going to be wanting to monitor them for complications like shortness of breath or bronchospasm. Because they may go into a bronchospasm and then they may start coughing. If they have asthma, that may trigger an exacerbation. COPD, same deal. Their O2 may drop on us if they're coughing a lot. So really our deal with the pulmonary function test is that education, and then monitoring during the procedure. So this is talking about a bronchoscopy. There's flexible bronchs and there's a rigid bronch. Again, this is just a tube that we put down. It's got a scope on it. It goes down. It can go into the bronchial tree, see what's going on. Flexible bronchs can be done bedside. A rigid bronch is done under like an OR situation, surgical suite. We can take samples, you can take tissue specimens, you can just look around, you can do deep suctioning, all sorts of stuff. So really, we did bedside bronchs at our hospital all the time. Different physicians are going to have different meds that they like. They may use a paralytic, they may use sedation, depending upon what's going on with your person. So as the nurse, you just get all the things ready. You're also going to want to have emergency equipment ready. You're going to do the note taking on the procedure, pre and post vitals, vitals during, all of that stuff. If it is a planned bronchoscopy, our person needs to be NPO for at least 8 hours before the procedure to help reduce possibility of aspiration. We're going to talk about how our person tolerated the procedure. We're going to be in charge of the timeout, confirming who our patient is, that this is the procedure being performed, all of that stuff, that consent has been signed. So lots of things to think about with a bronchoscopy. Thoracentesis. So this is just when a needle is inserted into the pleural space. There we go. Pleural space to remove excess fluid or air. This can be a diagnostic treatment, just seeing what's going on, or it can be a treatment, right? So diagnostic test or treatment, sorry. Normally completed under local anesthesia. So our person is fully awake, you just you numb the area, right? This also can be done bedside. This is going to be a sterile procedure though. We may aspirate fluid, send it for culture. Patient preparation, we're going to need informed consent. We're going to do education. The patient is awake. So first of all, they need to hold still, right? So we may be the one at the head of the bed, holding a patient hand, assuring them, all of that stuff. We're going to want to, again, make sure if you're doing it bedside, all the equipment is ready, that we have emergent equipment ready. Nursing implications, baseline vitals, post vitals. We're going to talk about how the patient tolerated the procedure. If they are unable to lay flat, you can have the head of the bed 30 to 45 degrees. So we're going to want to think of that. We're going to be monitoring vitals and pulse ox, all this stuff. You do not want to drain more than 500 mils due to risk of hypotension. And your pulmonologist should know this, but sometimes maybe you have a newer doc. Maybe they're not necessarily paying attention to that. Maybe they're just so sucked into making sure they get all the fluid out, right? So as nurses, we're going to be wanting to be paying attention to how much fluid is coming off of our patient. More than 500 mils, you run the risk of hypotension, and this can be a problem. You can cause fluid shifts. You can cause air shifts even in and out of the pleural space. So It's a big deal. We need to monitor that. We're going to listen to lung sounds, and we're going to monitor for possible complications such as a pneumo. So we're going to want to do an x-ray, right? Just to make sure that there's no air in the pleural space. We're going to want our person to cough and deep breathe. That's going to help reduce the risk of atelectasis and promote good lung expansion. So get those lungs back doing what they're supposed to do. We're going to place a dry, sterile dressing over the site. We're going to look for drainage and bleeding. We're going to make sure that it's not a copious amount of drainage and that there's not a copious amount of bleeding. Let's see. They may be discharged home after a thoracentesis. We're just going to educate them about signs and symptoms of complication and wound care. We want them to notify the physician if they have elevated heart rate or heart palpitations, dyspnea or shortness of breath, chest pain, or coughing up blood. Okay? So that's the education we would want to do. A lung biopsy, like any biopsy, they're going to go in, they're going to take a piece of tissue, look at it under a microscope. This can be percutaneously or an open procedure. Type of biopsy is going to be based upon what they're looking for, right? Location, size, all of that depends on what they're going for. Why are we doing this biopsy? Typically, we are looking for lung cancer, sarcoidosis, or pulmonary fibrosis. Abnormal values can indicate infectious process or malignancy. Patient preparation. So this is nursing. Education, consent, NPO for 8 hours. They're going to get general anesthetic. Let's see, post-op period. They may have a chest tube, right? So we're going to have to know what to do about a chest tube. Depending on the type of open biopsy performed and the patient's respiratory function, patient may require intubation and mechanical ventilation in the post-op period. We are in charge of doing the timeout, positioning. If they get a local anesthetic, right, at the site of the biopsy, we may need to be the anxiety support, right? We're going to watch our pulse ox, our vitals. They may not be able to move or cough during this procedure. So we're going to be there holding our person still, talking them through, keeping them calm, all of that stuff. If it's an open biopsy, that's more than likely general anesthetic. So all the things related to a surgical procedure. And of course, we document how the patient tolerated the procedure. All right, now we are talking about infectious respiratory diseases. We are going to start with flu. So type A and B are usually what we are concerned with related to public health concerns. Outbreaks of flu are tracked. They're tracked by CDC and they're tracked by the state and county health departments. That is done on an annual basis. And then, CDC compares that to the US. Types A and B are responsible for the epidemics. There is influenza type C. Influenza type C is not associated with epidemics. Efforts to control the impact of flu are focused on type A and B. Our vaccinations are related to type A and B. The primary event that initiates an influenza infection is the aerosolization of small droplets. So particles less than 5, and they usually fly like 3 to maybe 6 feet, right? So when you sneeze or when you cough, these droplets, these sputum droplets can fly, and that's how people end up getting infected. And then people touch a contaminated surface, then they touch their inside of their nose, mucous membranes, mouth, mucous membranes, and you end up contracting the flu. And we call those inanimate objects fomites, in case you haven't heard that. Now, keep in mind in a hospital situation, like these fomites can be stethoscopes, scissors, pens, all the stuff that we use. So when we are using different stethoscopes, if we are not using stethoscopes that are specific to the patient, we are going to be wanting to clean all our stuff, clean our scissors, clean our pens. You know, keep in mind that those things can carry disease on them, right? Incubation period from initial droplet inhalation to symptom development can be 18 to 72 hours. Severity of symptoms kind of depends upon how much virus is shed during the replication phase, and number of respiratory cells affected. It's also going to be dependent on the overall health of the person, right? So virus shedding usually ends 2 to 5 days after symptoms first appear. Therefore, it is important to remember that individuals are infectious for up to 7 to 10 days, okay? 7 to 10 days on flu. Clinical manifestations. So usually our clinical manifestations going to be more severe than a cold, and they're going to have kind of a more rapid onset. So we may see fever, headache, sore throat, nasal congestion, cough, muscle aches, tiredness, pains, malaise, so general feeling of being unwell, and fatigue. Diagnosis is going to be a respiratory secretion for viral culture. The thing is that can take like up to 10 days to get back. And by that time, you've spread your flu around the community, right? So unless you're in a contained environment, really contained, that that viral sample not really doing us a whole lot of good. So we tend to use the rapid influenza diagnostic test. Thanks to COVID, we know these are called the rapid tests, is what we call them. This can take less than 30 minutes to diagnose. They can even differentiate between A and B. So that's pretty much what we're going to see used is the rapid test. Treatment, there are antivirals out there, but really what they recommend for treatment is getting your annual vaccination. So the only thing with the vaccination is if you have an allergy to eggs, it is contraindicated. The vaccine is actually grown on eggs, and so it ends up with egg protein in it. So if you are allergic to eggs, you should not get this vaccine. There are alternative forms of the vaccine without the protein, so there are still options out there. We want to get this vaccination before the flu season begins. It takes a little while for the vaccine to start working and for our body to make the antibodies. So about, a month or 3 weeks or so before flu season. That's why you see it offered in October. These days they start offering it in September. I don't know. I disagree with the September, especially for Arizona, because we have a late flu season. But whatever. Just keep in mind it takes about a month for that vaccine to work in our body to make antibodies. So meds, like I said, there are antivirals, but really we think about antipyretics and analgesics to help with the fever and the aches. We want adequate fluid. That's pretty much it. Complications, really your biggest complication is going to be related to our geriatric community. So people over the age of 65, and that's going to be secondary bacterial pneumonia. So you can end up with viral pneumonia related to flu, but then if you think about the fact that we've got all this fluid and all this stuff sitting in the bottom of the lungs, and maybe our person is not coughing adequately, it is the perfect environment for bacteria to get in there, rear its ugly head, and you can end up with a secondary bacterial infection. This slide 50 is risk factors for flu infection. Flu, like COVID, is young children, older adults. Occupations, guess what? Healthcare workers, because we are exposed to it. And then you get family caregivers, daycare people, right? Anywhere where little kids are going to cough on you, you're going to be at a bigger risk. Immune system compromise, obviously, are people with autoimmune disorders, HIV, anybody on chemo, transplant recipients. We're going to worry about them being more susceptible to the flu. Chronic illness people. Don't forget that we consider our diabetes people in that immunocompromised category. And then, of course, we worry about our pregnant people because there is not a whole lot of stuff they can take to help with the flu, and viral pneumonia can increase in mortality rate of pregnant women. This is just about RN considerations. So we're going to do our normal assessments. Because this is respiratory, we're going to worry about hypoxia, check out the respiratory system, lung sounds, all of that. People come in with flu, we're going to want to slap a surgical mask on them. This is droplet isolation. So again, droplet isolation, we're thinking those big fat respiratory droplets travel about 3 feet, maybe 6 if they're a little bit smaller. So get your masks on your people. Our teaching is going to be related to hand hygiene, disinfection of household items. Again, with the fomites, I touch it, then I contract it. Limit contact for 10 days. Report worsening respiratory symptoms, because again, that can be a secondary bacterial infection. And then we want to encourage people to get their vaccine. This is a safety alert during the flu season. Antiviral medications have the best effect if taken within 2 days of symptom onset. Honestly, if you don't take it within those first 2 days, really doesn't do a whole lot for you. And it doesn't completely get rid of the signs or symptoms, it just kind of lessens them. This is talking about pneumonia. So 90% of pneumonia related to deaths are in people greater than 65 years old. So it really hits our older population hard. 16% in children under 5. All right. Risk factors: advanced age, long-term care residents, smoking, chronic respiratory diseases. So this could be asthma, it could be COPD. Again, we talk about our immune dysfunction people, people who have altered mental status, right? Prolonged immobility because nothing's moving. Aspiration of stomach contents or foreign materials. So again, with that, that is because things get down into the lungs and then they can grow bacteria or make us more prone to have a viral pneumonia. Exposure to air pollutant, gases, noxious inhalants, and then any hospitalization greater than 42 hours. Our signs and symptoms: fever, tachypnea, dyspnea, chills, cough, myalgia, fatigue, maybe some blood streaked sputum, maybe dysrhythmias, possibly hypotension. Awareness of the clinical manifestations and predictors of increased mortality related to pneumonia. This is slide 54. You want to look at this slide. So these are signs or symptoms that our person could die from their pneumonia. Altered mental status, respiratory rate greater than 30, hypotension, systolic below 90. All right, hypotension, systolic below 90, heart rate greater than 125, body temp less than 95. Remember, our immunocompromised people can go hypothermic on us, or a temp greater than 104, right? That is a crazy temp for an adult. That is not particularly a crazy temp for a kid. We see that with kids, but for adults, that is a crazy temperature. Let's see. So altered mental status. I'm running through these again. Altered mental status. That's a sign or symptom of hypoxia. Respiratory rate greater than 30. My body is fighting to breathe. Hypotension. Systolic less than 90. That is an unstable person. Heart rate greater than 125. My heart, oh my God, working to keep that oxygen moving. Body temp less than 95, or greater than 104. That's Fahrenheit. The other one is a PaO2 less than 60. Remember, our PaO2 is what we look at on an ABG, okay? Pneumonia medical management, diagnostics, labs, and imaging. We're going to do an x-ray. What are those lungs looking like? What has happened? Treatment, going to be based on type of pneumonia. If it's bacterial, we're going to see antibiotics. We also may see neb treatments, right? Bronchodilators, that sort of thing. Steroids, maybe. Steroids are going to take down our inflammation. That's what they do. That could be inhaled, that could be PO. Complication. There is necrotizing pneumonia dependent on the bacteria. Necrotizing pneumonia. It can eat cavities into your lungs. With TB, it will form cavities in your lungs. Empyema, so you can end up with blood in the lungs. Bacteremia, the bacteria can get into the bloodstream. Atelectasis, your little alveoli can collapse on you. Organ failure, release to decrease perfusion. Our body needs a certain level of O2 to maintain functioning. Without that level of O2, the organs may just shut down, and that's a whole other problem, right? So as nurses, our pneumonia considerations: vitals, neuro, respiratory, labs, ABGs, and I&O. I&O matters because of the kidneys. Our kidneys can decide to not function. So our person may end up with acute kidney injury. We need to be monitoring I&O. A difference, give or take, of 300 is okay. Anything more than that, for the most part, is where we become concerned. Now, if your person already has kidney malfunction, that criteria may be a little more strict, but that is going to be dependent on your person. So we're going to want to give oxygen as needed. Our person may tire easily, so we want to cluster care. Do all the things that we can do at one time so that our person can then get adequate moments of rest. Teaching, hand hygiene, rest, meds as ordered. If our person goes home on antibiotics, teaching related to take all the antibiotics, right? And then, of course, if your respiratory status gets worse, let us know. Because let's say, like we talked about with flu, if you have viral pneumonia, it can turn into bacterial pneumonia. And then there is a pneumonia vaccine. It is recommended for older people. We do want to make sure that we educate related to that. Now we are talking about tuberculosis. Tuberculosis, airborne transmission. So it's going to be our negative pressure air rooms. We're going to wear, hello dog, that's Charlie. We're going to wear an N95 mask. The benefit of an N95 mask is that it is fitted to our face. So those tiny, tiny respiratory droplets cannot get into us. We are protecting ourselves from the TB patient, right? There's also this thing called latent TB. That means their inactive bacilli remain dormant within the healed granuloma of the lung. So this person was exposed to TB at some point in their lives. Their body fought it off, and what the lung does is form a granuloma. It encapsulates the bacilli into the lung. This person is not infectious. The problem with latent TB, though, is if the person experiences some sort of autoimmune distress or, gets sick somehow, that bacilli can reactivate. So the person can end up with TB, right? And so all of that can reactivate. Let's see. Know that TB is a mycobacterium. We have other bacteria in that family, mycobacteriums. That does not mean they're tuberculosis. It's mycobacterium tuberculosis. All right. So latent TB, again, is you've been exposed to the disease, but you have no signs or symptoms. Your body fought it off. Your lungs have formed granulomas, encapsulated the bacilli. A lot of times, if you have latent TB, they will go ahead and treat you for TB to hopefully get that taken care of. Primary tuberculosis infection is often asymptomatic and non-infectious. Symptomatic TB infection is a primary progressive TB infection. This is what we worry about, symptomatic TB. The TB is getting worse. The person is infectious. They can transmit TB to other people. And then what's going on right now is, or what we're seeing a little bit more often, is drug-resistant TB. They just had an outbreak of drug-resistant TB in Kansas back in 2023, and they're currently going through, Kansas is going through a TB outbreak right now. To be honest, I haven't looked to see what that's related to, but if it was multi-drug resistant back in 2023, fair chance they're seeing drug-resistant TB right now, and that's scary because we already use a cocktail of medications related to TB treatment. And multi-drug resistant TB is just that much harder to treat. So diagnosis, we're going to look at labs. We're going to do a skin test. We can diagnose via chest x-ray. Now, there is a tuberculosis vaccine that is only given in areas where TB is endemic. So places like India, if you're from India, you may have received the BCG vaccine. Places, certain areas of Mexico, you may have received the BCG vaccine. So this is a vaccine. So that means our body has produced antibodies to the tuberculin, okay, or to tuberculosis. So if we are given a skin test and I have antibodies, the skin test uses tuberculin. It's a protein derivative of TB, right? And we're looking for antibodies to respond. But if you've had the vaccine, you have antibodies, so you may get a false positive on your skin test. You don't really have TB, you don't have latent TB, you just have antibodies related to the vaccine. So if you are ever in a position where you are administering TB tests to staff or out in the community, one of the questions you're going to want to ask is, has somebody received the BCG vaccination? All right. Treatment for tuberculosis is a 4-drug combo, and this is continued for 9 to 12 months. Compliance is our #1 issue. 4 drugs, 9 to 12 months. Definitely compliance issue. Tuberculosis is actually, because it's considered a public health threat, a court of law can mandate you to receive TB treatment. You can also be placed in a facility if you are non-compliant with TB treatment. If you can be ordered to take TB treatment by the law, okay? This is like one of the only diseases that they will do this with, but that is because of the public health threat that TB poses. So just kind of an interesting FYI with that. This talks about, this is slide 59. You're going to want to take a look at this chart. This is related to the PPD skin test. So when we do the PPD skin test, what we are looking for is if an induration forms. An induration is where that area turns red, it puffs up, it forms what looks like a bug bite, it's itchy. You know, when we go and read a skin test, we are looking to see what that induration is at. Now, an induration of 5 millimeters or greater is considered positive in an HIV person. A person having recent contact with somebody with TB, or a person who has fibrotic changes in an x-ray that indicate that they had previous TB, or immunocompromised people. All right, so 5 millimeters or greater in our immunocompromised people, or people who have had recent exposure to TB. 10 millimeters or greater in recent immigration from a high prevalence country, IV drug users, residents and employees of high risk settings, mycobacteriology lab personnel. So if you work with mycobacterium, if you work with TB, if your induration comes back 10 millimeters or greater, we're going to consider that positive. Kids younger than 4, infants, children's, and adolescents exposed to adults in high-risk categories. So 10 millimeters or greater, you've got some risk factors going on. 15 millimeters or greater is considered positive in any person. All right. So anybody, if you don't fall into those risk factor categories, 15 millimeters or greater is what we're going to be looking for. This is a safety alert. If you suspect TB at all, any part of you suspects TB, we want that person in airborne precautions. We do not want them contaminating our entire facility. We do not want them contaminating other people. Moving and transporting people needs to be limited. We would put a surgical mask on them if we have to move them from setting to setting. You want to, those surgical masks, I mean, it's not an N95, but surgical masks a lot of times have the little wire over the nose, so you press that in. We want it snug fitting if possible. Also remember that as healthcare providers, we want to wear our N95. Believe it or not, CDC teaching forever that I can remember is that you can keep your N95 in a brown paper bag for 3 days and it is okay. All right, that is okay. A brown paper bag is permeable. Your N95 is going to dry out. CDC has been okay with this for a long time. During COVID, I saw people putting their N95s in like plastic Tupperware containers. There were even videos on YouTube about how to, take your mask off and put it in your container, seal it. The problem is Tupperware containers are not non-permeable. This is not breathing. You are creating a nice, moist, warm environment for that TB bacteria to proliferate. That is not safe practice. So when you see if your facility has you put your N95s, brown paper bag, you can keep them up to three shifts. That is actually CDC approved for a long time now. Okay, seems weird, but it's okay. TB considerations. So we are going to think vitals, sputum, breath sounds, isolation, O2 as ordered, meds as ordered. Remember, it is that up to 4 drugs, 9 to 12 months. So teaching, we are going to want to make sure that the people understand med compliance. Also, if you have family members or if this person was sitting out in your waiting room, we're going to want to test people that were exposed. That may be you as a healthcare worker, right? So people are going to need to be tested. We also want to talk about their personal support. When I'm talking about having to take all those medications for 9 to 12 months, a support system is really going to be helpful, being my cheerleader. Hey, did you take your meds? Don't forget your meds, right? And then, of course, community support. Weird TB med considerations. So when we talk about, and I'm sure you talk about this in pharm, but when we are talking about what meds we want to memorize, there's those gold standard drugs, the one that's like the prototype for this class of meds. But there's also weirdo things related to meds that as nurses we're going to want to know. And a lot of those, a lot of the TB meds have some really weirdo things. One of the things is like rifampin. So rifampin can actually cause your body fluids, tears, sweat, urine, sputum, to become like a red-orange color. It can even stain your soft contact lenses. So this is definitely something we're going to want to educate people about, right? Because imagine going home and nobody tells you that with rifampin, your body fluids can turn like orange. You're gonna lose your mind, right? So that's definitely a point of education. Also, a lot of the TB meds are really hard on the liver. So we're going to want to warn people about like signs and symptoms of jaundice, maybe persistent GI effects, abnormal bleeding. Rifampin can also cause problems with glycemic control in diabetic patients. So maybe your diabetes was under control using metformin, if you're type 2, and now all of a sudden your sugars are nuts, right? It can be related to the rifampin. And don't forget, when we're talking drugs that are hard on the liver, we say no alcohol, not just some alcohol. We really try to go with no alcohol. You do not want to become pregnant or breastfeed during the course of therapy with rifampin. That's a huge one. We always want to think about pregnancy considerations. Isoniazid, a lot of times will be used is used with TB, but it can cause peripheral neuropathies, which is weird. So to avoid peripheral neuropathies, we recommend taking like a B6 supplement with that. That's a weirdo thing, right? You also want to avoid foods containing tyramine, which is like your pickled, cured, smoked things, any aged cheeses. Do not get pregnant or breastfeed with isoniazid. Any signs and symptoms related to toxicity. So this could be decreased urine output, dark urine, clay colored stools. That is that is related to lack of bile, skin rashes, anything like that. So look over this slide. This is slide 62. And always remember, when we're talking medications, if there is something weird about that medication, you're going to want to remember it, okay? Because that is a focus point. So that concludes this first PowerPoint related to respiratory. Unfortunately, there's a second one.